Okay, it's 7:05, so why don't we get started and we'll continue our discussion as more people join in. Even if we have a thin attendance, I think it is good enough for us to engage in a meaningful discussion. So good evening all. All the attendees here, they are very frequent visitors of this session. So we are going to skip the usual introduction. I have already shared the case discussion in the WhatsApp group. I will speak it out one more time and also a clarification that Praveen has asked. So this is a 55-year-old male, 55-year-old female. The story goes that around 5-6 days ago, this lady came on a video consultation with me. She has a history of hypertension. She takes this tablet called triolmizest, which she takes every day at night after dinner. This triolmizest is olmizest 40 milligrams plus amlodipine 5 plus hydrochlorothiazide 12.5, and that is her chronic medication. She usually does not check her blood pressure at home. She otherwise is fine. She recently got positive contact, as in her husband got positive with COVID. So she also got herself tested and her test also came positive. So since then she had been in home isolation. The family has got son, daughter-in-law, and a grandson. The rest of the three are okay. It is only the husband and wife who are COVID positive. She didn't have any obvious symptoms, although when I probed her, some general malaise, fatigue, tickle in the throat, those kind of things are there, but nothing particular. And she consulted me mostly to see if there is anything that she needs to do other than home isolation. And for that, I recommended her to take some vitamins, take paracetamol as needed, and to keep her hydrated and whatnot. I also asked her to check her oxygen status as well as her blood pressure at home. So that was the video consultation. Now, a few days after that, she texted me at night at around 10:30, 11ish or so, that post dinner, she was having some mild headache. So she had her dinner, took her medication, and watching TV, and had mild headache or so, for which she took a paracetamol, and she waited out for some time. After an hour or two also, the headache didn't subside, nothing too bothersome, but because she was very mindful of her recent COVID, she was being extra careful. And then at around 10:30 or so, she messaged me saying that, hey, I'm getting mild headache, what to do? I asked her to check her blood pressure, and the blood pressure reading with the digital machine at home came 220 over 110. So certainly that's pretty high with a pulse rate of around 84. So I asked her to relax, kind of dim her room lights and just, close her eyes and settle down, relax for 20 minutes and then recheck her blood pressure. She had already taken her usual medication around 2 hours ago. So she rechecked her blood pressure again, and it's again 210 over 110. Now, I don't know what her baseline blood pressure readings are because in the last 3-4 days since she chatted with me, she didn't check her blood pressure at home. And even previously, she had not been checking her blood pressure routinely. Her last physician contact was more than a year ago. So we don't know her background blood pressure as well. So now she's there. It's been about half an hour. Her blood pressure remains 220 over 110. Mild headache is there. No other symptoms otherwise. She's feeling fine. And she asks over the phone what to do. Now, I have to give her an advice for this blood pressure. Of course, in my opinion, it couldn't wait till next day. So the questions that are going to come up for this particular clinical situation is, should we just continue to ask her to take rest, maybe take a nap, blood pressure will eventually settle, or take an extra dose of the regular tablet that she's taking, understanding that it has got, it's a fixed dose combination, so it has got 3 drugs that she'll get. None of them are fast acting drug. The options are either she directly goes to the hospital right now with the intention of reducing her blood pressure, because if we have to define, this would be classified as hypertensive encephalopathy, where she's getting a little bit of headache. Or we give her some other oral tablet. We just ask her family member to go and grab some tablets from the nearby pharmacy store and give it to her. Or we try something intravenous at home as well, understanding that there is obvious concern of COVID among the family, and also whether she's going to get a bed. The problem is, as you know, these days, COVID bed availability is also a problem. So now we have got this patient at home, high blood pressure. How do we go about it? Should we leave it? Should we do something? If we do something, what do we do? What would be a strategy? And I can understand that there is not going to be a wrong or right answer. We'll just discuss what each one of us, how each one of us will handle this situation. So let me go with Praneeth to get his impression, and then we will go around with the attendees here. Praneeth.
Yeah. Good evening, everyone. So I would basically see this patient as hypertensive urgency. So whenever we see patients having higher blood pressure, the first thing is to look at target organ damage. The headache that is been attributed, I do not think is a part of her hypertension, because headache is a bit non-specific symptom which need not be always related to hypertension, and I believe in this case that hypertension is not related to her hypertension, and I would consider this diagnosis as hypertensive urgency, not as an emergency. Having said that, urgency is not something where there is no need to drop the pressures immediately. I would try to look at reasons why she could have had this high blood pressure. You already said a patient was relaxed and rechecked and it's consistently high. So all those anxiety, which is quite common in this time when there is COVID going on, when you already have a diagnosis of COVID, most of the time patients are having hypertensive so-called crisis where pressures are getting elevated. So this patient, I believe, is not having any of those things. But having said that, higher blood pressure, no significant target organ damage, I would advise this patient to relax and kind of not react to the higher blood pressure. Regarding the management, I would still again say wait and watch, not do anything. No need to take the fixed dose combination, no need to equally take any shorter acting drug or anything right away. Overnight, need not do anything. Also advise her not to go to any hospital, both from patient point of view and also from the administration point of view, because one patient is a potential contact where she can spread infection. So I would ask her not to go, and equally going there, getting the beds availability and the value of going to the hospital and getting evaluated for the so-called hypertensive urgency right now, I don't think adds much value. So I would ask her to wait overnight, just relax, lie down, recheck her blood pressure again tomorrow morning, and if it is consistently high, then try to advise her to take some medication and optimize her blood pressure. So I would just wait and watch, do not react to that blood pressure, reassure her and ask her to keep monitoring her blood pressure. That is my take on this patient.
Praneeth, question, when you say relax, just behavioral relax, or would you give her some sedative or something relaxant or whatnot? What is your take on this?
In case if she says that I'm quite worried about this issue, the most important thing is reassurance. If patient is convinced enough about this thing and she's okay, I would leave it at this point. Versus if she's quite anxious and she says that I'm not able to get sleep or anything, then I would suggest to take a small dose of sedative on an SOS basis, something like alprazolam.
Perfect. Thank you, Praneeth. Let us continue our discussion. And I have got memory of who all was present at 7:01, who listened to the entire case scenario. So I will ask those attendees. So Dr. Praveen, you heard the entire clinical scenario. If you could unmute yourself and walk us through how would you handle this situation. I'm not very comfortable with Praneeth's decision of leaving her overnight with 220, let's say. Let us see what you have to add.
Good evening, sir. Good evening, everyone. Say, for example, if the same patient has called me and has said, "Sir, I am having this high reading," I would ask her to have the blood pressure checked again, and I would be worried how the blood pressure was checked. What you call, whether most of the times they just check in a what you call in a manner that is not recommended by the for the electronic blood pressure monitors. The worrisome was that previous reading was not there, and we can't just take one reading and get worried. But at the same time, her blood pressures are on the higher side, and whatever the mild symptoms are there, we should consider it to be pointing to the one. Why? As her headache did not relieve by the Dolo 650 she has taken. So the other thing I would do is that after almost 30 to 40 minutes, if she had checked her BP and the blood pressure is still on the higher side, I would give a shorter acting drug rather than that of the fixed dose combination. I would give a shorter drug and check her BP. And if it's still on the higher side, if she is having the ongoing headache, I would ask her to visit a nearby hospital for the condition what she is suffering. If, for example, if the headache has been relieved and the blood pressure has come down, I would ask her to review the next day to come to the hospital. Keeping aside the case, sir, most of the times what happens is the electronic BP monitors, whatever they are having, it should be usually checked on the same arm, and the average of 3 readings sometimes most of the machines will be giving. But they say that the electronic BP monitors should be calibrated with that of the mercury sphygmomanometers at least every 1 year. Most of them they do not do, and that should be done. And considering other non modifiable factors, probably after she testing positive, the other family members might also have test positive, and she might be concerned for that. That might have raised her blood pressures and all that. These would be my concerns, sir.
Praveen, before I let you go, that short-acting medicine in this particular patient, give me your choice.
Sir, it would be amlodipine 10 mg, sir, because the onset of action, they say it will be 30 mg, within 30 minutes. Or I will not give nifedipine, sir.
So in her combination, she already got 5 milligrams of amlodipine, so you would be okay giving her 10 more of this. I just want to make sure.
Yes, sir, 10 mg more.
Okay, perfect.
If one of the question was there, no, sir, the other medications to be given a treatment at home, one of your question was that.
Right.
So if the blood pressure is again 200 by 110, it is an offline recommendation. I do not know if I am wrong. Please correct me. Most of them give isolazine also.
Right. Right.
Yes. Okay.
Okay. Thank you, Praveen. We're going to continue our discussion. Thank you, Praveen, so much. We will continue with our discussion. I think Dr. Shankar was with us since the very first minute that we logged in. Dr. Shankar, if you could please unmute yourself, share your thoughts about it, and also the calibration thing that Praveen just mentioned.
Good evening to all. The patient, index patient, is taking 3-drug combination in the evening, and she has come with hypertensive urgency. So there is no target organ damage. But first of all, when the patient complains of severe headache, suddenly with accelerated hypertension, which strikes me is thunderclap headache, I will go for CT scan to rule out any pathology in the brain in the form of hemorrhage or subarachnoid hemorrhage, or as you said, hypertensive encephalopathy, other conditions which giving rise to the drowsiness in this patient. That is my way of approach here. After CT only, I will move further.
And sir, how about managing other? So the problem with this particular case is getting her out of the home and doing something. So while you would recommend her to get out and get CT scan, is there some first aid that you would like to advise to her, or you would just do anything after CT scan only?
The same thing is which is discussed now so far.
Okay.
We give her Calpol or Crocin or Dolo 650, and anxiolytics also we give, and we give again the same this amlodipine 5 mg and as well as telmisartan or losartan 50 mg or telmisartan 40 mg I give, because here the blood pressure is significant. It is 210/110 repeatedly. So we have to reduce BP here. Short acting means only amlodipine, and the same sartan also can be given as a telmisartan, though it the onset of action is a little delayed, but at this point of time in the night we can give only, we can ask her to continue telmisartan or losartan plus amlodipine 5 mg more.
And sir, give us your thought process regarding this BP calibration. We have discussed this in one of our previous Huddle session, but if you could just give your 1 minute thought about BP calibration, machine calibration.
This calibration is very much important, because since we are using electronic apparatus nowadays, this is the mode of recording BP everywhere. We have discarded the mercury manometers, so the electronic BP apparatus has to be calibrated. So I don't know the details, but it has to be calibrated. That every year that machine has to be calibrated.
I would love to hear any attendee if they have ever got their patient's machine calibrated. I think I would love to hear their thought process. And while we do that, I'm going to continue with my discussion for this patient here. Let me see. We have got Dr. Santosh with us. Dr. Santosh, I hope you got the clinical case. I have also pasted the clinical case summary in the chat box, so people who have joined later, please go through the chat box. You should be able to read the clinical case. Dr. Santosh, sorry, how would you manage this case if a patient would have called you at 11 o'clock at night with a blood pressure of 220/110 and mild headache? How would you manage this patient? Santosh, please unmute yourself if you can hear me. Okay, maybe
I can hear you, sir. I can
yes,
hear you, sir.
yes, Santosh, please
So this blood pressure
describe.
of 210 was after taking the triple drug combination, sir?
Yes, after 2 hours.
So after 2 hours, if the patient blood pressure is 210 with a significant headache, I would like to admit this patient and do a neuroimaging, sir. Then in this patient, I will advise admission for. I'll treat as a hypertension emergency rather than urgency. It could be a starting symptom of press also. So that will be my approach, sir.
So Santosh, the reason why we are discussing this case is because in the current situation, if you want to admit her, you won't get success. I don't think CARE has a bet to admit this patient. So the question is not just about recommending admission. We also have to look at the pragmatic situation, what we can do right now. So one of the biggest issue currently is getting a bed for this patient. So I do agree with your approach that we should think towards admitting this patient. But what if you can't get a bed? What if there is problem with her coming out? Is there something else that you can do to her?
At the maximum, we can give another dose of amlodipine and see, sir. That's all, because 5 mg of amlodipine already is there in combination. You can give 10 more mg of amlodipine and assess the blood pressure of after 1 hour. If the symptoms persists and the blood pressure is still high, then it's better to admit at least that time.
Perfect. Thank you so much, Santosh. I'm going to keep moving. And while I do so, I have, as I said, I have pasted the case summary. I have also in the chat box uh, sent a link of a website called Stride BP. Stride BP, I believe, is a website from UK. If somebody is looking at the website, they can correct me if I'm wrong. And this website talks about BP calibration and the need for it and how to do it, and also lists all the blood pressure medication digital machines which are currently available in the market, at least in UK market. A lot of them are available in Indian market, and talks about which of those machines have been tested, calibrated and tested versus which has been not. So it may be a good resource for you, and it has got downloadable PDF as well that you'll be able to assess. Having said that, I'm going to keep moving. Let us see. Dr. Sandeep is with us. Dr. Sandeep, I hope you got the clinical case that we are discussing right now. If you could please unmute yourself and tell us how you would approach this patient.
Uh, the Basically we all agree with the case that the case needs admission, as we are all on the same page that the case needs admission, and it needs a proper assessment of the neurological for any focal neurological deficits or any hypertensive encephalopathy, see if, examining for any target organ damage or anything like that. But at the current scenario, so we have decided that this case, since the unavailability of the beds or whatever, or the specialist, or we want to treat it in the home basis itself. So the first thing itself, am I audible?
Yes,
Hello?
Sandeep, you're audible. Yes, you're audible.
Yeah. So coming to the case, so we have to treat her at the home. So the first point comes whether the BP recording, whether the BP recording itself is accurate or not. So at that night, I do agree with the calibration issues and everything, how the patient has taken, whether she is relaxed, whether she has taken any caffeine, or whether her legs are crossed. These all form the issue. But in that night, in the emergency, when the patient is having headache, I don't think we have time to check all these. Probably we can make suggestions, but at the same time, it will not. I don't think we can make much difference in that scenario. So in that scenario, a simple way is whether if any neighbor's pygnomanometer, like electronic BPAP test, is available in that point. If available, if by chance, that is one way we can check in that point of time. uh, Again, this has got practicality issues because the patient is COVID positive, and if the BP recordings continue to be the same when double checked by any other apparatus or by any other professional in the same scenario, then the what is left with us is a treatment. So in the treatment, first we have to check the compliance, because the patient is already stressed because of the COVID positive status for her or for her family. So the compliance is very important. Whether the compliance is there or not has to be checked. And the second thing will be, I would go along with an antihypertensive. I would suggest for an anxiolytic. So anxiolytic, I suppose, makes a difference in this patient. And regarding the antihypertensive medication, amlodipine, she has already taken 5 milligrams. So I don't think any more for amlodipine, the total daily dose will be of 10 milligrams. So you can give 5 milligrams more of amlodipine, or any short acting calcium channel blocker like nifedipine, uh, and a diuretic. These two with an anxiolytic, I think should improve her symptoms in the coming duration. Why? Because most probably this episode might have been triggered by the uh, recent COVID status or whatever. That's my analysis.
Thank you very much, Sandeep,
And
for your answer. And I'm just reading what Praneeth has written, how much of reduction in BP that we are expecting, because amlodipine may not reduce it quickly. I think that is my concern as well, Praneeth. If I give amlodipine right now, I don't expect it to work, at least for the next an hour or two. And then short-acting drugs have unpredictable reduction of BP. That also is, that point is also well taken. Prescribing out of hospital setting can be risky in theory, yes. And I think that is the whole purpose of why the discussion continues. So anyway, let us see what other people are suggesting. I am looking for, in the meantime, if anybody has got any question, comments, or any thought process, they can please unmute yourself. Dr. Ataullah Khan, I hope I'm audible to you, and I hope you got the clinical case. If you can hear me, can you please unmute yourself and share with us how would you manage this patient in terms of treatment and in terms of the urgency of going to the hospital? Dr. Ataullah, if you can hear me, please unmute yourself.
Sir, I think the same thing. I think I would first give a short-acting calcium channel blocker, and then I would just ask her to record her BP at home when she's resting comfortably. Then I think with each recording, she can just inform me her BP value, and based on that, maybe if she requires adjustment of her antihypertensive medications, we can do that.
Perfect. Thank you so much, Dr. Ataullah. And I think that this, in my opinion, is not that uncommon of a clinical scenario that we face, because pre-COVID, sometimes I used to get these kind of calls from the periphery, where some person is at village and they happen to check their blood pressure, either because somebody else was checking and then they also happened to check, or they were having some non-specific discomfort and they checked it. And sometimes it is chicken or the egg, in terms of they're anxious, they check their blood pressure is high, and you don't know whether the blood pressure is high because of if they are getting anxious because of high blood pressure, or is it that the high blood pressure is actually causing the anxiety, or anxiety is causing hypertension. So I think that sometimes it goes into this chicken and egg kind of situation. And there also you have to make a decision where you need to figure out whether you want to send this patient to hospital immediately, or whether you want to give them a home treatment trial. While we don't want to undertreat, at the same time, we don't want to overtreat people. It doesn't make sense for us to keep rushing patients to the hospital if we can make a reasonable judgment that this patient probably would be okay at home. So I think that is one of the critical decision making that is going to be with this particular patient, because when we talk about absence of end organ damage, well, we don't know if this patient has end organ damage or not. Clinically, symptom wise, there is only mild headache, and mild headache is very non-specific. But at the same time, for other end organ damage, you need to do investigations, which unfortunately we are not able to do in this case. She's at home. So we have to take all of this into consideration and understand and then advise in terms of seriousness. Of course, if I tell this patient that no, you have to find a hospital, there is just no way we can manage it at home, then they will have to find a bit. There is just no way. That is not an excuse anymore. But then I need to come up that strong in front of this patient, and that is where the discussion comes into play. So Dr. Srinivas, you joined a little bit late, but I hope you got the clinical case. I have put it in the chat box as well. This is a 55 COVID positive lady at home whose blood pressure is 220 over 110. And we are discussing how to manage this, understanding that she may not get a hospital bed right now in a routine situation. So Dr. Srinivas.
Yeah, Dr. Anoop, considering that she is in stage 3 hypertension and we don't know if there's any end organ damage, and do we have any baseline creatinine in this patient?
You know, her last physician visit was more than a year ago. And at that time,
Sure.
her labs were okay.
Okay, and she's not on any NSAIDs or antihistaminics to cause the acute surge in BP.
You know, the only medication I have advised her, and that's what she promises she's taking, is some vitamins and paracetamol along with her triolmazest 40 tablet that she takes. Other than that, if she had taken any ibuprofen or something for this COVID, I don't know, but she denies taking any other than paracetamol.
Okay, and does she have a pulse oximeter? Or do we know her heart rates to see
Yes,
whether it is all anxiety related?
Yes, her pulse oximeter is there. Her heart rate is in 80s and oxygen is fine.
So it's not too high a heart rate to attribute the entire blood pressure to anxiety. Certainly, I would like to step up her BP medications, and you have already given her Stamlo. And since she is not symptomatic and she is only 55 and her past renal functions are okay, probably we can still wait for a few hours if there are no beds. But if there's any acute shortening of shortness of breath, breathlessness, or if there's any further increase in headache or vomiting, certainly we can't wait with the blood pressure of 210, 110. And yes, we can't just wait on one antihypertensives. You have already added one more, and anxiolytic you are already prescribed. We can wait for a few hours. Only thing is, who's going to check her blood pressure again? We have to rely on the patient herself because she's COVID positive. That's another tricky situation here.
Yeah, right. The only respite is that at her home, she and her husband, both of them are positive. So both kind of in the same room take care of each
In
other.
that case, we have to rely on the machine on which she is checking the blood pressure.
Yeah.
Hopefully, she has a decent blood pressure monitoring machine at home.
Right.
And we have to be in touch with her. If there are no beds, I think the only way is she has to make sure that she's going to get in touch with you, and we have to be in touch with her. That's the only way.
Right. Well, that whole bed thing is also that I discussed that, you know, if we very strongly believe that this has to be managed at home and then in the hospital, and that there is nothing that we should be doing at home, then we can certainly convey in that regard to say that, you know, this kind of situation are managed in the hospital. There is no way you're going to be at home. So while
we can wait for a few hours since she's only 55. There's no other comorbidities. Presuming her LV function was okay, renal status is okay, there's no end organ damage, and she has a mild headache, we can still wait for a few hours. But if the BP is not coming down, or further worsening of headache, or if there's any acute shortness of breath, I don't think we can wait anymore. Only glitches, she is COVID positive. So whether she'll get a bed in this present situation, I mean, that's a tricky situation. But yes, she has to come. If the symptoms persist, she has to come.
Right. Thank you so much, Srinivas sir. We have got Chandramukhi madam here. Ma'am, I hope you got the clinical case. It is there in the chat box as well. And it's this 55 female COVID positive that we're talking about with a blood pressure of 220. How would you manage this patient at home? Is there something different that you would do? Please share your insights.
Good evening, all. Thank you, Anoop. So, like in this period of pandemic, really our decision making has changed a little bit, taking into consideration that she is a COVID positive case. So, if it would have been other like normal situation, and then I would certainly have told her to come to hospital. But in this scenario, like when she's COVID positive and we are short of beds, and again, then I would like to tell her that already you have told that you have added amlodipine and anxiolytic. So I will also do the same thing and will tell her to monitor her BP at home only. And if she develops any symptoms like any headache, vomiting, as already Srinivas has told, then she can report to the hospital. Thank you.
Perfect. Thank you so much, ma'am. Anybody has got any questions, comments, thoughts, anything, they can unmute themselves or raise their hand. I'm still looking for anybody in the audience who ever delved into calibrating their blood pressure machine, digital blood pressure machine. If anybody has ever tried or succeeded or failed or anything, I would love to get their insight. This is a question that pops up every single time whenever we talk about home monitoring. And I don't think any one of us got a very good understanding of how to manage this. So this becomes a little bit tricky at times.
Anoop,
Yes, sir.
we used to have one apparatus which has a dual connection. That requires a dual connection testing machine. We had it in our outpatient. We used to do that when we were at care hospital.
Okay, sir, maybe if you see any search or if you find any search, we would love to get our hands on or at least see in person how it works. I'll tell you what.
Actually, there is outpatient in Banjara. Please check on that. We didn't take away that apparatus. We left
Okay,
it there.
perfect. I will check upon that, and if I do find, I will make sure that I share what I found with the attendees here. I think it will be interesting for us to know how this works. I will tell you what I do. I tell my patients to buy blood pressure machine, model of which is listed on the Stride BP website. And only those recommended blood pressure machines are to be used, and many of them are available in India pretty cheap. And secondly, whenever there is a discrepancy or whenever there are numbers which are not satisfactory, then what the kind of calibration I do is literally I just have them bring their machine and we check it with our machine and we check it with their machine both at the same time. And we verify either the calibration is right or wrong. If the calibration is wrong, I don't have an apparatus to correct the calibration. If the calibration is wrong, we just tell them to get a new machine. But if the calibration is correct, which means the numbers are about 4 to 5 millimeters here and there, I tell them that it's okay to continue using that machine. So I verify the calibration, but I'm not able to fix an off calibration when this happens. So that is what I do. Of course, in this clinical scenario that we are discussing, it won't be possible. It's late at night. And even if the machine calibration is wrong, at 220, you would expect it to maybe 20 points here and there, but certainly it won't be in the normal range. It certainly is going to be higher than what your threshold would be to be comfortable. So that is my take on it. If anybody has got anything to discuss, they can unmute yourself. I will ask Dr. Somaraju to give his suggestion about how he would handle this particular case, and then I'll share what I did with this patient as well. Somaraju sir, if you could please unmute yourself and share with us how would you manage this patient at home, and if you would simply tell the patient there is no way we are managing at home, you need to come to the hospital.
Actually, thank you, Anoop. And as somebody already pointed out, I think Dr. Praveen, when they take blood pressure at home with a electronic apparatus, so at least 3 readings have to be taken. They should be sitting by the side of a table on a chair without any other movement, and the arm fully resting on the table, etc. Praveen already pointed out. I'll leave it there. Having said that, one thing I will ask this patient is it the first time this type of headache happened to her, or earlier she used to have headaches on and off? That makes a difference. Then, secondly, the combination of 3 drugs generally are not reliable in their absorption. And somehow it happens they are not to be relied upon, particularly in situations like this. And thyroid is not a choice anti-hypertensive diuretic because it is not longer acting enough. And if you ask me, I won't admit her. And she had a previous history of headaches. And if this happened first time, if there is some vomiting or something to suspect something more, I'll ask her to come to hospital. Otherwise, I'll keep manage her at home. And also I'll take away that combination medication and change her over to individual drugs. And then I won't give 10 milligrams stat of amlodipine. I will give either 5 milligrams or 2.5 milligrams, and I'll ask her to check the blood pressure again. And I don't mind giving a 20 milligram tablet Lasix in the first dose. After that, I will change her over to say chlorthalidone, 12.5 or whatever is the requirement, and change her over from olmesartan to some other say RB, ARB. And then the amlodipine and other doses have to be slowly adjusted according to the requirements. And so to re-emphasize, I won't ask her to come to hospital, particularly if she had headaches earlier on and off. And secondly, I won't straight away give 10 milligrams amlodipine. Suddenly she may go into hypotension. It is not good even if there is a intracerebral complication. And then want her to check the blood pressure. Again, tell the family member, whoever is available, and keep in touch and follow it up at home, and then make decisions as things develop.
Sir, one question. You said to change olmesartan to some other sartan. Please share your thought process. Why is that?
If blood pressures continue to be high, I'll change it over to say something like sartan or even telmisartan, divided doses, etc. Because olmesartan, the increasing doses don't help actually. That's the problem with it.
And sir, since you mentioned, I believe a lot of the audience know, but for the completion's sake, if you could give your thoughts why you don't like hydrochlorothiazide and you like chlorthalidone more?
Hydrochlorothiazide is less than 12 hour acting. And once you give a diuretic for any patient, for any reason, whether it's hypertension or heart failure or anything, the kidney acts avidly to reabsorb sodium. And they don't have a continuous activity of diuretic acting upon them. Chlorthalidone is 24 hours or 36 hour acting. And thiazide is no longer a choice antihypertensive. The night shoot up of blood pressures, particularly if they take the drug in the morning, is particularly common.
Perfect. Thank you so much, sir. I think that this discussion is very pertinent in terms of, while there is not much of groundbreaking science here, I think a basic discussion goes around in terms of what to use, how much to use, and when should we alert ourselves to send the patient to the hospital. Again, the idea is very simple. It is, I think it will be very easy if we find anything abnormal to the patient at home and suggest them to come to the hospital to be safe. I think that will always be that will always be okay, but we have to balance the strategy of safety versus how much extra burden we are asking to the family and the healthcare system as a general. So a lot of this discussion which are not research oriented or scientific oriented, but more of what how we manage clinically, that comes around. So I'll tell you what I did to the patient, and I think this is one thing which I want people to think about. Whether that is the right way or not, I don't know. I will ask people's opinion. Many of the times, hypertension and hypertension related ailments are very common. Cardiac issues, diabetic issues, they are very common. So every single time, this is the point I have made it. And I remember when I came to India at that time, particularly in the village, when I was there for 3 months, just chilling, I see that in the village, doctors, whenever they get a new onset hypertension patient, alprazolam was a routine prescription in every single patient. And I used to wonder why are we treating hypertension with alprazolam? Only to understand that for these doctors, maybe one of the anxiolytic was one of the safer way of reducing the sympathetic drive and reducing the blood pressure response. as compared to just over treating with other medications. And the second thing is trying to understand what is available at home. So every single time when a patient calls me with a high blood pressure, I ask them who all is in the family and what all disease is there in the family. Because many of the times, the treatment and the drugs and everything, they are just around them. Like for this particular patient, her husband had her husband had an MI, and he was on all the routine cardiac medications for the past 4 or 5 years or so. So he was taking antiplatelets, he was taking anxiolytic, he was taking beta blocker and whatnot. And the BP machine that the lady was using was actually her husband's blood pressure machine. So first, I had an in-house calibration where I just asked her to check the blood pressure to her husband, and her husband's blood pressure was fine. So that way, I kind of got to understand that maybe the machine is working okay. Then I asked what all medication her husband takes. And one of the medication that her husband had was a sorbitrate to be taken SOS. So I said, okay, you have got one medication right up there. Let us see whether it works or not. So rather than giving it sublingual, I told her to take 5 milligrams of oral sorbitrate, like how you take normal tablet rather than a sublingual tablet, because I didn't want the blood pressure to drop precipitously. So I gave her a sorbitrate tablet. I asked her to report the blood pressure back to me within half an hour and an hour. And she reported back to me about 45 minutes later saying that her blood pressure, now the machine reads below 200. It's still high, still about 190, 192. Now she was checking more frequently, but the blood pressure was coming a little bit higher. So at that time, I told her to take 5 milligrams of amlodipine again, which her husband was taking, and take 1 alprazolam and just sleep. So that's essentially what I did, and she did fine. And of course, that is just one anecdote about this particular patient, how I handled. But the point that I wanted to discuss, which was a learning for me a few years ago, was look into what is available at home. Because a lot of the things that we kind of think about and whatnot, we can get answer at home itself. Many of the times they have family members who have got pretty much every single thing that you're asking for. So that was how I managed this patient. So 5 milligrams of oral sorbitrate, followed by 5 milligrams of oral amlodipine after an hour, and 0.25 milligrams of alprazolam, and asked her to sleep over. And if there is any problem, then inform. The same problem that we discussed about in terms of nausea, vomiting, worsening headache, any new chest pain, discomfort, breathing difficulty, and all those kind of things. So that is what I discussed. I'm just going through some of. Yes, sir.
What happened today after sorbitrate?
Sir, her headache was mild, and I think she did report her headache improved, but I'm still skeptical what was the cause of that headache. A lot of it could be behavioral placebo, whatnot, but her headache did improve after sorbitrate. Again, I don't want to make much out of it, but to answer your question, it did improve after sorbitrate. I think her headache could be because of blood pressure as well. I saw her the next day in the OPD, by the way. I mean video consultation, not in person. And there we discussed about antihypertensive regimen. I have a BP chart which I give to my patients. So next day when we discussed, I gave her the BP chart. It's a digital blood pressure charting, and I discontinued her fixed dose combination. I also like chlorthalidone more than hydrochlorothiazide. As a matter of fact, I take chlorthalidone as compared to hydrochlorothiazide. So that's a drug I like. So I changed some of our medications. I asked them next day to get some blood evaluation done, which included creatinine as well and potassium. I wanted to make sure that those numbers are okay. So home collection was done for those labs the next day. And I did not change her olmesartan. I thought that all the sartans, they work the same. So I did not change her olmesartan, but I increased her amlodipine from 5 to 10. And I changed her hydrochlorothiazide to chlorthalidone. That is some of the changes that I did for this patient. Any questions or comments, please share it with us. I'm just reading what is written on the chat box. So Praveen asks, house opinion on the use of isolazine in such cases if patient is COVID negative and not willing for admission. Praneeth replied to that, I would not consider isolazine as there are better alternatives to reduce BP. Praneeth, I would ask your thought process onto it. If I wouldn't send a patient outside to buy an isolazine, but if the patient has got isolazine with them, I certainly would consider it as a reasonable medication to take to reduce blood pressure. I would again ask the house about what their go-to antihypertensive effect at home is. I personally use clonidine quite frequently in a situation where I cannot send the patient in the hospital. So any patient with hypertensive urgency at home, like these, where they don't have cardiac issue and whatnot, if I have to send a patient to go to pharmacy to buy a shorter acting medicine, I personally advise them to get clonidine along with whatever amlodipine and whatever I'm asking for. I send them to get clonidine because I know most of the time I will get a predictable response within an hour or two. That is what I use. I would ask people, I would ask the attendees for their opinion. Then the other question is any possibility of COVID as a cause of hypertensive urgency. I don't think of any. There was one patient of COVID who had a renal artery thrombosis and he had very high blood pressure. That is one situation I can think of. After 3-4 months, his requirement of antihypertensive came down quite significantly because the blood clots resolved. That is just one case example that I have got. Other than that, Dr. Srinivas writes, if she is obese, then her cup size might need some fixing. I agree with that, sir. She could be obese. I cannot tell you for sure whether the cuff was fitting her or not. That I did not verify. Praveen, your comments on why isolazine is not your favorite drug and what do you think about my approach of clonidine? Praneeth, please unmute yourself.
Yeah, so I do not agree with isolazine or any of those shorter acting agents for that matter is because of this unpredictable drop in blood pressure, which by itself can be detrimental and precipitate a stroke or an MI. So I am not in favor of using any of the drugs, oral drugs. And you mentioned about clonidine. Yes, clonidine works efficiently, but again, the same issue is that what if it works more than what is desired? And I am not comfortable and haven't tried any time. I would, in case when I desire to reduce the blood pressure, I would try to get the patient admitted. I would rely on injectable drugs where those are shorter acting agents and I have reasonable control on reducing blood pressures like nitroglycerin infusion or something, where I'm much comfortable and add them simultaneously add a longer acting antihypertensive like amlodipine, etc. So that is my take. So I'm not comfortable, and hence I do not agree with that idea. And isolazine, like as I said, because there are other alternatives, and I look isolazine more in relation to management of heart failure. I don't particularly see it as an antihypertensive agent because there are other alternatives.
Dr. Praneeth and Dr. Anoop, I agree with isolazine. It's not a routine antihypertensive. Second thing I wanted to also point out, when somebody comes with severe hypertension and headache, nitroglycerin is not the first choice because it influences blood-brain barrier. Be aware of it.
Sir, Somaraju sir, what is your thought about arcamin, clonidine in these situations?
The problem with clonidine is that the heart rate responses and central actions will and also alteration, sometimes the drowsiness will confuse the issues. Somebody came with headache and hypertension, should wait until blood pressures come to a reasonable level. After that, you can change over.
Perfect. Thank you, sir. I think the reason why isolazine comes up quite frequently in my assessment is because while we don't have IV hydralazine in India, or at least I have not got any success in using it, in my training program, IV hydralazine was one of the first line agents for hypertensive crisis or hypertensive urgency in the emergency. So there we quite frequently used to use IV hydralazine followed by oral hydralazine as a short-term blood pressure response drug, and later on convert it to something longer acting. So for the first 24-48 hours, amongst other drugs, hydralazine was one of our early drugs to be used in a patient where we were not that worried about any major cardiac illness. Because of reflex sympathetic activity in IV hydralazine, they sometimes cause tachycardia and whatnot, but that was our way, and that is why it got stuck in my head.
And Dr. Anoop, I must add here, isologine is not the drug of choice in most of the antihypertensive situations, emergencies or urgencies. Correct me if I'm wrong, it is insurance driven in US, and because it's a very cheap drug.
Yes, sir, it is insurance driven. I agree with that. It is just that so first of all, we never used hydralazine for chronic blood pressure management. Hydralazine is not a blood pressure drug, so we never used it for chronic blood pressure management. For acute illness, we don't care about insurance. For acute illness, if a patient comes to the emergency with some discomfort, in the United States, we are at our liberty to use whatever we want without any company approval at that time that we need. So in the outpatient, a lot of our decisions were based upon what insurance would approve. But in the emergency, almost all of our decisions were clinically oriented, at least what we thought was the best for the patient. Now, whether what we think is best for the patient is actually best or not, that certainly requires discussion and debate. But in the emergency, we rarely were bothered about what insurance approves and what does not. It was completely in our control. So anyway, that was what we used to think. And again, to emphasize, hydralazine or a combination of hydralazine and nitrates, they are not blood pressure. They are not antihypertensive drugs. By no stretch they are. But whether we can use that for short-term control of blood pressure, that is what we are discussing here. And the way I got trained, we used to use it far more liberally as a short-term control of blood pressure in the first 24-48 hours, along with other drugs, that it didn't have to be a single drug in that way. So that is why I have a soft corner for that drug. And then the other issue of concern with hydralazine is the lupus syndrome that hydralazine can cause. And that also, since we are talking about hydralazine, I'll just highlight. The lupus syndrome with hydralazine is mostly seen with a daily dose that exceeds 300 milligrams, which means patients who are on 100 milligrams 3 times a day, which some of my heart failure patients were in the United States. They were taking 100 milligrams 3 times a day. But in India, where we give isolazine 3 times a day, there the drug has got 37.5 milligrams of hydralazine. So effectively, they are getting just about 120, 125 milligrams of hydralazine daily, which is nowhere close to what we typically used where we saw lupus kind of syndrome. So hydralazine can cause this non-specific fever, malaise, rashes, and all this when they are used at higher doses, and that is typically 300 per day. So that's another thing what I wanted to just throw out, because I believe that we in the Western Hemisphere used far more frequently than here. Any other thoughts, questions, comments, how to manage blood pressure? If I may take 2 more minutes, I'll just ask one more question. Praneeth, I'll ask you this question. And then if anybody has got any thoughts, we can share for another minute and then we'll close. So once a while, we get this patient in our OPD. And this is a different case that I'm talking about. Once a while, we get patient in our OPD who are feeling fine, who just came in for a routine checkup. You do blood pressure assessment and their blood pressure is 210, 200. They are feeling fine. You tell them to get admitted and they say, doc, I'm feeling absolutely fine. Why would I get admitted? Yes, my blood pressure is high. Change my medication. I'll go home. Now, these patients with a blood pressure of 210, 220 in the OPD, they are feeling fine. You hesitate to send this patient home with that blood pressure because if it rises, then they are in trouble. You hope it will go down, but if it rises, then they are in trouble. So how do you manage these patients in the OPD? Do you give them some extra medication in the OPD, have them wait in the waiting hall for some time, let the blood pressure come down and then go home? How do you manage? Because this is a far frequent scenario that we get in our OPD. Praneeth, give your thought process. You have a patient in your OPD with a blood pressure of 220. What will you do?
Yeah, I would try to advise them admission, and if they refuse admission, then again I would ask them to wait for an hour, recheck their blood pressure, and try to again convince them about the elevated blood pressure, which sometime patient may buy. And if still the patient refuses, then I would advise them to I give them medication and ask them to review in after 2 days or something like 3 days, and then keep them under a short follow-up. That's what I would do.
So, so the question here is it okay for the patient to go back home with a blood pressure of 220? Or would you do something to make sure it comes down in the hospital before they go home? Do you do something of that sort?
No, I don't do anything. I don't want to reduce the blood pressure quickly.
Yeah, because when patients come to me, I think this is another difference in how we practice our individual medicine. Because when patients come to my OPD with a blood pressure of 200, 220, absolutely asymptomatic, will not get admitted because they are feeling absolutely okay. There, I make sure I give them an extra medication in the OPD, let them settle around in an empty room for half an hour with their family or whatnot, or an hour for that matter, get their blood pressure down. Only when their blood pressure is downtrending, and downtrending means at least 10-20 millimeters blood pressure needs to come down, so that I have this feeling that by the time they will go home, their blood pressure is going to get a little bit better. Then I send them home rather than sending them home with that blood pressure of 200, 220, because I don't know which direction it's going to go. Sometimes I have sent these patients in emergency, no admission emergency, where they just, rather than sitting in that single room, they sit in one of the corners in the emergency where somebody is checking their blood pressure every half an hour, again with an oral medication to make sure the blood pressure goes down before they go home. So I think these are clinical scenarios for which we don't have good scientific knowledge, but we need to figure out how we do ourselves. Somaraj sir.
Dr. Anoop, I do the, almost something similar to what you said. I don't admit them, give them a medication, wait for an hour or two, 2 hours or more, recheck. And second thing, it requires excessive probing and almost go out of the way to ask use of NSAIDs, use of cold and cough medicines, nose drops, etc., and herbal medicines. Many of them don't think they are important unless you ask specifically, go out of the way to find out.
Perfect. Thank you so much, sir. This is 8:07. It is 8:07 now. Anybody has got any thoughts, questions, comments about what we are discussing? One of the basic aspect of the huddle discussion is try to understand the very practical scenarios of how we deal with our patient situation rather than discussing what research said or what science said, because for many of these scenarios we really don't have a clear-cut scientific guidelines to back us what we would be doing. So I think discussion like these are very important. And anybody has got any thoughts, we would happy to discuss. If not, then we'll close the session. This is 8:08. So Praneeth, your closing comments for today's discussion, and then we'll close the session.
Yeah, one comment which I already mentioned in the chat box is about COVID as a cause for hypertension or hypertensive emergency, because the consults which I saw in CCUs and ICCU about patients who had COVID who are ventilated, there is a noticeable autonomic dysfunction leading to hypertensive crisis as well. So that is one thing which I had to say. And concluding the session, a very practical scenario with no clear-cut guidelines and a difficult situation where you want to do something and at the same time patient has his own hesitancy. But as said, discretion of the individual patient, discretion of the physician based on the individual patient. Whenever in doubt and when conditions are feasible, always try to be safe and get evaluated, get admitted patient. And when situations are not conducive, then do the best. I like that concept of using the in-house medication and trying to get out of the situation, and then keep following the patient, reassure them, and get back to them and make sure that their hypertension is well controlled on the long run, and educating about the need of properly measuring the blood pressure, calibrating the BP machine and all should equally be emphasized. That is what.
Thank you so much, Praneeth. And I believe all the attendees by this time, they are well aware that we are on YouTube and podcast. I am actively uploading content on those. I think on YouTube, we have got about 20 episodes uploaded, and on podcast, we have got about 36, 37 episodes uploaded. So you can look into that. I have shared the link in the chat box. And I've also shared the link of the WhatsApp group that we have created where we discuss some offline content of the current discussion. So once you join the WhatsApp group, if there is anything that you want to add regarding today's discussion till next week, please feel free to share it with us so that even offline we keep discussing about some of these scenarios. And I will look into our OPD if we have that calibration machine that Dr. Somraju was discussing about. If I do find it, I will try to make a video or a picture of it and share it on the WhatsApp as well. I thank each one of you for sparing your time and participating in this very practical discussion. Also, if you have any topics that you think we should discuss for our weekly huddle, please share with us on the WhatsApp group as well. We will try to find out how we can discuss about that particular as well. Thank you all, and I hope you stay safe with this COVID pandemic. Good night, and we'll see you next Wednesday. Thank you, everyone.